Hello, my name is Nehal Desai, and I will be briefly talking about reproductive disorders, um, specifically um, the mechanisms of actions of some of the drugs used in this disease state. Um, you may have seen some used, or may have dispensed some in the pharmacy in the past, um, but we're going to look at some of the specific mechanisms and how they work. Specifically for testing purposes and understanding um, the mechanisms, the basic mechanisms of each of these medications as they're used in practice and also as you may see on the exam. So, um, as mentioned previously, these are the main topics that's covered on the exam. Um, You can see here we already covered a couple of these. The first top three, the diabetes, the thyroid disorders, adrenal disorders. Just giving preview of the mechanisms of some of the drugs used in these disease states. Now we're going to look at reproductive hormones. Um, so mainly uh, it's going to be mostly on female reproductive hormones, but then we're going to talk about the male as well. There isn't so much in the male part, but it is still essential and important, especially for the exam. So I'm going to cover some of that for you. Um, so just take a look. Um, so again, like they are divided into male and female parts. In this, in the first few sections, we're going to talk about the female reproductive hormones. Um, that's used to treat like polycystic ovary syndromes, endometriosis, menopause, infertility, and then we'll look at the male parts, which is a benign prostatic hyperplasia, erectile dysfunction, hypogonadism. So let's take a look at these. Um, and also, so there are some sexually transmitted disease infections, or STIs. I'm not going to completely look at all of these. Um, or at least talk about these in this presentation. But I'll give you an overview of the types of treatments that's used for treating these disease states. We will talk about more about infectious disease when we come to that section of the course. So, as of right now, we're just talking about the concepts as they relate to endocrinology in the exam portion. So, in terms of the polycystic ovary syndrome treatments, these are some of the medications that's used to help with it, treating some of the symptoms as well as, you know, um, in um, either like preventing progression to pregnancy or increasing pregnancy progression. Um, some of these medications, I'm sure you've heard of oral contraceptives or see them in the pharmacy. Um, they are not just used as birth controls, but sometimes they are used for certain disease states to control symptoms, before patient goes into pregnancy. So we'll talk about both parts of the contraceptives because there's a progestin and estrogen. So we're going to talk about both parts, how they help in polycystic ovary syndrome as well. Um, Metformin, we already discussed it, but just to give you a general idea, metformin is important because some of the hormones that's used, insulin is also kind of play a role in the direct relationship with some of the, I guess, the luteinizing hormone, the follicular stimulating hormone as well. So that's an important concept. I would recommend you take a look at a little more closely um, as well as while you're studying for your exam. Um, Spironolactone has some role in it as well. But again, I already discussed mostly these mechanisms previously. You can take a look at them in any of my previous presentations where I discussed about spironolactone, metformin, um, and trying to connect that with some of these other disease states as well, because there is some direct correlation with some of the hormones as well that plays a role um, in the reproductive disorders as well. Um, Letrozole, I'll talk about that. Clomiphene as well. These are two. Uh, these are two unique mechanisms. I don't believe I have discussed previously, so I will discuss them in this presentation. Um, and uh, and it, and also weight loss has some benefit as well in you know treating some of the symptoms of polycystic ovary syndrome as well. Endometriosis, that's usually where like there's an overgrowth of tissues outside of the uterus when it normally grows inside the uterus. So we're going to look at some of these medications as they play a role in the mechanism of action of treating endometriosis. Um, you're not going to see a lot of um, very exclusive information or on direct relationship in treating that disease or curing it, but at least to see how they work in the body. That's what we're trying to look at, the mechanism mostly, the integral part of how and why something, uh, why the, or basically understanding how these drugs work. Um, just the basic concepts. NSAIDs, it is pretty painful and overgrowth of tissues, and all that inside the body, and then you see a lot of stretching and pain that occurs. So, NSAIDs are pretty important, especially when to treat pain. So, I may have included a slide on NSAIDs, but if not, you can go back and look at one of the shorts that I created previously on that. Um, it's a very basic concept. NSAIDs, they just block the COX inhibitors, the COX-1 and COX-2, um, to prevent, further pain, decrease inflammation, and all of that. So take a look at that. That does have some that does have some benefit in patients experiencing pain while they are um, undergoing endometriosis. So take a look at that. Um, I also want to mention the leuprolide. Leuprolide is an important medication, especially for the GnRH, or one of the um, hormones that's used to increase the LH and FSH, and then estrogen as well. So you'll see a split between the agonist and the antagonist. I wanted to show that on one slide so you can see like the differences here. I guess the agonist will somehow become an antagonist if overused, and I'll show you that in the future slide. And progestin, it's kind of connected to the combined oral contraceptive, so I'm going to show you piece by piece on that too. Menopause or hot flashes, those kinds of things may occur, mainly due to, and you can see on the slide here, the SSRIs, where serotonin and norepinephrine gets imbalanced in the central nervous system. So essentially when that happens, like that's especially when there's a decrease in serotonin and norepinephrine goods really erratic, for example, and um, gets out of whack. Um, that's when like the temperature starts to kind of, uh, just causes the hypothalamus to increase the temperature and cause hot flashes to occur. So we'll look at a little bit about that. Gabapentin, you'll see how um, uh, the voltage gated calcium um, channels are actually um, blocked so that the calcium does not get into the neuron or the brain cell, and prevents that excitatory um, neurotransmitter from occurring, so it doesn't um, cause any of that to occur as well. Clonidine, similarly, it kind of connects directly with the SNRI, specifically norepinephrine. Um, it's going to block the presynaptic terminals of the alpha 2 receptor, so that the norepinephrine just does not get released. It stays within um, the nerve cell, so it doesn't um, decrease as well. So it maintains the temperature that way. Um, so we'll take a look at some of these. Infertility. Again, these are some other drugs that's used for infertility as well. Gonadotropin is a unique one here, HCG. Gonadotropin, these are mostly like direct binding LH and FSH type of drugs. So you'll see some of that. HCG is usually just the LH direct binding drug. And so these two, particularly the gonadotropin and the HCG, play an important role in infertility. And then the BPH, alpha 1 blockers, that is important as well. So you can see all three of these in a way will are used to improve or relax the smooth muscles. So like in the prostate, for example. So that tissue doesn't like overgrow in the prostate. So it kind of like um, decreases that enlargement. Um, so you'll see some of that, how they work. Um, yeah. And then uh, similarly, erectile dysfunction PDE5 inhibitors are used here. And then testosterone for hypogonadism. Sometimes the certain tissues in the body cannot produce the testosterone. So that's why you might see in the pharmacy where testosterone is typically dispensed to patients. Um, is to help increase those testosterone levels for various different tissues and areas where testosterone is not being produced as it should, and which is used to convert to DHT or dihydrotestosterone, which is active medication to, allowing action in certain parts of the body, especially increasing some hormone levels and muscle mass and energy and all of that. So we'll take a look at this as well. Again, these are some of the STI treatments. I'm not going to cover this in this presentation, but I wanted you to at least take a look at that as it relates to reproductive disorders. Um, infectious disease is where I'm going to mostly cover these medications. Um, but you can see here, like doxycycline, uh, penicillin. I'm sure you've heard of penicillin being used for syphilis mainly. Um, and then doxycycline being used in multiple STI treatments, as well as ceftriaxone. Um, I don't think we see a lot of metronidazole used in STIs, but there is some benefit as well. So I put it out there so at least you can see that it has some role in treatment in um, STI. Um, so, and so this is just one of the medications. There are other ones. I probably did not add a couple more medications in this list. Um, but like I said, there are um, other medications which I'm going to discuss mechanism. I meant to list them all here, but I guess I must have missed the part about the whole list here at the end here. But you'll see all these medications mechanisms in the next slides anyways, so let's take a look at them. So the first one is the progestin mechanism. Progestin typically works by binding to intracellular nuclear progesterone receptors. They are basically located in multiple reproductive tissues, including the hypothalamus, the pituitary gland, the cervix, the endometrium, the fallopian tube, ovaries, breast tissues. And then when they're bound, um, what happens here? They're going to move into the nucleus, and maybe I can try and draw it out here. So they're going to move into the nucleus, okay, of that cell. And then once they bind, so let's see, this is that receptor. Once it's bound, it's going to cause some sort of gene transcription. And that's going to cause all these other effects here, like the GnRH and the thickening of the cervical mucus, thinning the uterine lining, tubule motility is slowed, and the follicle maturation. It's immature actually, so you can see it's going to inhibit that GnRH and do all of these things to prevent um, you know, especially for the egg from being released, essentially. All these different little components here to prevent it. So it's going to definitely decrease the LH and FSH because it's going to, if you're going to inhibit a GnRH, then you're also going to prevent the release of LH and FSH. And so this is going to prevent the follicle from fully maturing, and that is where the egg cannot be released, and it prevents ovulation, so thereby preventing pregnancy. So that's the basics of how this medication works. And like this cell could be inside a hypothalamus, pituitary gland, any of these in the list here, used to cause these types of actions. Then there's the estrogen, which is a little bit different. This one actually binds to the two types of estrogen receptors. There's an alpha and beta receptor. Now the alpha, estrogen receptor alpha, um, their their main things are they're just located in different parts of the body. So you can see your uterus, liver, bone, and breast, and the alpha and the beta is the bone, brain, cardiovascular tissue, ovaries. I guess beta in a way you can think of like beta blockers, cardiovascular in a way, and just in case it's on the exam. Um, so like similarly, it's going to go ahead and bind to this receptor and then move to the nucleus. Um, the same way as the progestin does. It's going to bind to DNA at the estrogen response elements and change the transcription to new proteins. So that's the basics on how this one works. And letrozole is another important one. Um, its main purpose is to bind to an enzyme instead of a receptor, like the progestin, the estrogen does. This one binds to an enzyme that actually converts the androgen to estrogen um, hormone. And so it binds to aromatase enzyme. And that's the basics of how this works. And when it does that, um, it's increases the FSH and LH and ultimately stimulating ovulation. So this is where like pregnancy would mostly occur through this mechanism. Um, so it will inhibit the transformation of androgen to estrogen. So that's what's gonna happen here. And usually this is in the ovaries, the adipose tissue, liver, brain, breast tissue. You could see like this is one of medication that will induce pregnancy instead inhibiting it, like the contraceptives. Clomiphene, similar, same way, but this one binds to the receptor within um, the hypothalamus tissue or cell. Um, you can see here when clomiphene binds, um, it's binding to the estrogen receptor. So you're not going to see estrogen being able to bind to that receptor because it's blocking it from binding it there. And so what happens is the estrogen will decrease. So that's going to increase the GnRH and increase the LH and the FSH, leading to ovulation. And then the same way here, and we see, but these are mostly the GnRH agonists. This is the one where I was talking to you about the agonist becoming more like an antagonist later on if if it's a pulse type of release, or if it's not released continuously, then it will increase the LH and FSH. But if the GnRH is continuously released and it, just keeps on doing it, or the medication just keeps on doing its action, then it's going to desensitize the pituitary part of the hormone and it decrease LH and FSH. And that's going to cause issues. So basically, when they first bind to GnRH receptor, they mimic the pulsatile GnRH, which increases the FSH and LH for a short time. But when the agonist stimulation becomes continuous, the pituitary becomes desensitized and the receptors downregulate. So it drops to almost zero. And then there's suppression of estrogen and testosterone. So they bind to the receptor but block it instead of activating it. So it kind of like acts like an antagonist later on. Whereas the antagonists, they antagonists bind to the receptor and then prevent the FSH and LH from being released. So it's kind of like very similar, the agonist and the antagonist. Just differences where how often it's used. So just wanted to show you that further use of the GnRH could lead to, what the antagonist does. And then the NSAIDs. This is from one of the shorts I already had previously uploaded in the past. This one is actually very similar. There's a mechanism of reducing pain, so I'm not going to talk too much about this since you may have already seen this. This is one example of a medication of an NSAID and naproxen. I'm not sure if any of your pharmacies have had or if you have ever had dispensed naproxen. But it is one of those NSAIDs. It is used to block COX-1 or COX-2, so it helps reduce pain, inflammation, fever, swelling overall. And decrease the prostaglandin, decrease uterine contractions and pain. So essentially, this is what NSAIDs do. So just keeping that in mind. NSAIDs are pretty much in any part of the body where there's pain, the COX inhibitor. So you just have to. This is not really a line of therapy to treat the reproductive disorders, but rather the symptoms of that disorders that are caused by that disorder. So, like pain, for example. So, NSAIDs are usually a vital part in as an adjunct in treatment of these kinds of diseases. SSRI, SNRIs, there's a lot of stuff going on in this drawing, but what I want to show you here is that the main thing is when there's a decrease in estrogen, then there's a decrease in serotonin, and when that happens, the temperatures of the brain area become a little bit uncontrolled. So it kind of like increases. A slight increase will lead to hot flashes. And so when the stability, when it is unstable, then that's what happens there. So to control that, they use medication as an SSRI or SNRI. And how it works is it actually blocks the transporter or the serotonin receptor transporter or the norepinephrine transporter. And when it blocks it, it's going to prevent the release of the serotonin and norepinephrine. So that's going to keep the temperature under control and prevent the hot flashes. So that's basically it. And the hypothalamus is basically stable again. Then this one, I don't know if I already explained this mechanism previously, but I'm going to explain it again. Gabapentin is medication that's used for nerve pain, but sometimes it can be used for other things too, especially if we're keeping like the hypothalamus temperature under control and all. So norepinephrine needs to be under control as well. So the calcium channel blocker are like the voltage calcium gated channels are usually blocked by gabapentin. So when they bind to it, it's going to bind to the alpha 2 delta subunit of the voltage gated channel calcium channels on the presynaptic neurons, and this will reduce the calcium influx into the neuron. So without the calcium entering, then there's no excitatory neurotransmitter, so it's not going to really excite there. And this stabilizes hypothalamus and reduces hot flashes overall. Clonidine will do the same effect, kind of, but in a different way. Clonidine is going to bind to the presynaptic part of the neuron, known as the alpha 2 receptor. And same way, I keep the norepinephrine in there and calm the hypothalamus. Gonadotrophin, I briefly already talked about this, but this one binds to the overend surface receptor, and then basically increase the FSH and LH, and then finally increasing estrogen levels. So that's how it will work here as well. Alpha 1 blocker. Okay, so that was it for the female reproductive parts. This is now the male parts. Mostly, again, it's to relax the smooth muscle. So when the alpha 1, I'm sure you've heard of alpha 1 agonists like epinephrine, how it can kind of vasoconstrict and cause that squeeze in the blood pressure and all that. So, same way, this is the prostate tissue or smooth muscle tissue, and it's going, when the alpha 1 blocker is used, it's going to help relax that smooth muscle overall. And in the 5-alpha reductase inhibitor, I briefly already talked about this. This is to prevent the conversion of testosterone to dihydrotestosterone. And the dihydrotestosterone is primary hormone responsible for stimulating prostate cell growth, and so that it does not enlarge. And so when the 5-alpha reductase is used, that enzyme converts it, but the 5-alpha reductase inhibitors prevent it from doing that conversion. So there would be more testosterone in the cell. And then this is another one, the PDE5 inhibitor. This will actually break down the GTP being broken down to cGMP. So it's going to lead to more smooth muscle relaxation here. And you can see nitric oxide is used to activate the guanylate cyclase. So that's how this whole thing happens here. And the testosterone mechanism, This is one of the medications you may have seen dispensed at your pharmacy. Um, it is a controlled substance, so, but it is one of the medications that you may have seen. So, testosterone mainly works. Um, it is a lipophilic steroid hormone, so it can easily cross the membrane and bind to androgen receptor in the cytoplasm. And then it moves into the nucleus after it's bound and then binds to DNA and regulates transcription of the genes. This produces the proteins responsible for like the male sexual development and function, and then restore like certain things like the erectile function, muscle mass, energy, mood, bone density, libido, um, all those kinds of things.